my pleasure to introduce Dr. Rupi Brar, who's an addiction family physician from Vancouver. And we're very excited she's going to be speaking about looking at the prevalence and epidemiology of alcohol use disorder. So I'll hand it over to Rupi. Thanks for joining us.
Thank you so much, Alan. So I'll just screen share. So first and foremost, thank you so much, everyone, for taking time out of your lunch hour to join this talk. I'll be reviewing pharmacotherapy for the management of alcohol use disorder. And as Alan mentioned, I'll definitely be touching on prevalence and epidemiology and the importance of that. So I first and foremost like to respectfully acknowledge that I'm a humble guest on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations here in Vancouver. And I have no disclosures to state here, and I'd like to acknowledge the BC Centre on Substance Use for some of the slides that I'll be using today. So as an overview, I'll review prevalence and epidemiology of alcohol use, review the low-risk drinking guidelines and some of the evidence behind that, screening and brief intervention, and the meat of the presentation will be relapse prevention, so reviewing pharmacotherapies for alcohol use disorder. I have some other goals for today, hoping to discuss the standard of care and this provincial guideline for people with alcohol use disorder, and determining why issues or what issues may be keeping people from accessing evidence-based alcohol use disorder care, and developing greater compassion and hope for people with alcohol use disorder, and potentially becoming a champion for the standard of care. And throughout the presentation, I'll use AUD as an abbreviation for alcohol use disorder. So just to start off, alcohol use and the harms are quite prevalent. In fact, 1 in 5 Canadians over the age of 12 drink in excess of the recommended daily or weekly limits. That's 20% of Canadians. 18% will have had the diagnosis or will have met the criteria of an alcohol use disorder during their lifetime. So not only are 20% of folks in Canada drinking above what's recommended, 20% almost also would meet the criteria for an AUD at some point in their lifetime. So that's 1 in 5 of our patients that we may be seeing in our practices. And so it's a really high number. Alcohol contributes to 8% of death in Canadians aged 0 to 64. And in BC, 26 deaths per 100,000 are due to alcohol use. So there are many harms and health impacts of alcohol use. Short-term, things like intoxication, injury, motor control, memory issues, and longer-term brain damage, stroke, heart disease, hypertension, many GI cancers and non-GI cancers like breast cancer, fertility issues, and the list goes on and on. And in fact, there's some data that shows that upwards of 200 medical conditions are associated indirectly or directly with alcohol use. And the economic cost. So overall, there's a high cost of substance use in North America. In Canada in 2014, alcohol cost the system $14.6 billion, tobacco $12 billion, other substances $11.8 billion. Now, this is based on productivity loss, the criminal justice system costs, but also healthcare costs, admissions, and requirements of the medical system for people who are using substances. So why was this alcohol use disorder clinical guideline developed in 2019? It was really to bridge the gap between research and practice. Like I said, about 20% of Canadians, so nearly 1 million British Columbians, annually engage in high-risk drinking. This generates, like I showed, a lot of health and social problems, growing hospitalization rates, and large societal costs. So in spite of the high prevalence, high-risk drinking and alcohol use disorder frequently go unrecognized and untreated in the healthcare system. In fact, a recent study published by a group in Saskatchewan showed that of those that had an AUD diagnosis, only 1.3% of those folks received a prescription for evidence-based pharmacotherapy. And so just moving on, why is that? So this is a JAMA systematic review and meta-analysis, one of many that was published in 2014 that looked at this one specifically, 122 RCTs, looked at various medications, both off-label and approved. And their conclusion was that there's a lot of evidence to support us to use pharmacotherapy for alcohol use disorder. So we've got the evidence. And further, many genetic studies have shown that there's an inheritability of substance use. This one specifically showed that alcohol use disorder is a heterogeneous disorder, and consequently, plan of care needs to be individualized. That in fact, alcohol use is inheritable upwards of 50%. And so what we know, and what this makes me think about, is other chronic medical conditions. So diabetes, heart disease, hypertension, those are chronic conditions that require us to use evidence-based treatment options, that require us to do longitudinal care. And we know that there's environmental and genetic factors that impact one's chances of getting those conditions. So similarly with substance use, we have good data that shows this happens to people that use substances. And so in fact, being able to give the same rigor to substance use and substance use disorders can really reduce harms for folks in our communities. And then trauma-informed care. So this is something we should strive for in every aspect of care that we provide our population. And when it comes to substance use, I mean, this study here, the ACEs study, showed that there's a strong graded relationship between the exposure of abuse or household dysfunction and subsequent morbidity and mortality. And so similar to diabetes and heart disease, people that have experienced trauma in their life have a higher risk of substance use and the harms that come from that. And so this is a slide I took from a colleague of mine, Dr. Christy Sutherland, and it's a very simple slide, but it really makes the point, which is why I like to use it. So in medicine, we don't want to ask the question, what are you doing? You want to ask the question, what happened to you? So if we know from data that substance use disorders are inheritable, that there's environmental factors, that there's a chronicity to them, we really want to know the fact that the person continues to use, and if it's harmful, how they're doing it, what happened, versus, the sort of more classic or more traditional approach of you shouldn't use substances, they're harmful. And this, in fact, reminds me of something that I did just 2 months ago. I mean, I've been practicing community and hospital addiction medicine along with primary care for almost a decade now. And I said to one of my patients who has a severe AUD, this had been their third admission for an upper GI bleed, and this last one was quite severe, resulting in an ICU admission. And I did a home visit. And the first thing I said to them was, I want you to know that this next time, since you're still drinking, the next time you drink, you could have a terminal bleed. And I want you to know what a terminal bleed means. But I instantly lost eye contact with my patient, and I instantly had filled them with shame. So I basically was insinuating to them that, you keep drinking and you're going to die. And maybe you don't know that, or that isn't of importance to you. But I know as their family doctor, they have many goals in life and many things that are important to them, but they have an extensive history of trauma and reasons why right now abstinence isn't an option. So, I've done some training in MI and various things, but it is sort of sometimes as a provider, you go back to your liver is failing, or, you've had an upper GI bleed and really need to consider not using, but that isn't a trauma-informed way to provide care, and it actually isn't effective. So goals of treatment, traditionally, again, when we think about someone who's had harmful effects of alcohol use, we really want to recommend abstinence. But really what the data supports is that we develop goals with patients that create a patient-centered plan. So maybe they want to reduce their drinking days. Maybe they want to drink less per week, or have less heavy drinking days. But overall, a common goal is likely going to be that you want to reduce harms and consequences to overall health. And you want to help restore the day-to-day functioning and achieve those goals. You want to bring hope to people with an alcohol use disorder. Like I've shown, it's extremely prevalent. Many of the patients in your practice are likely suffering from either high risk use or an actual alcohol use disorder. You want to empathize. Substance use is highly stigmatized in society, in our healthcare system. So it's a challenge for people to be able to bring this up to their providers. You want to explain to your patients how alcohol has affected their brain. You can talk about the genetic factors, the environmental factors. And you also want to explain how treatment can actually help heal the brain. And there is hope for people that drink alcohol who want to cut back or stop. And so the first thing I think that I want to highlight quite briefly, but to point out the importance of screening, because it's so prevalent, everyone should be asking about alcohol use routinely in their practice. Both adolescents, adults, older adults screen annually. You want to do routine screening to allow for early education and early intervention. So you're not just asking when red flags present. You want to adopt a caring and non-judgmental manner. I can give you an example where I wasn't using a non-judgmental manner and it didn't work well, but you want to use that approach so you can improve accuracy of self-report and really allow the patient to feel comfortable with them sharing their history of alcohol use. And there are many validated tools you can use in a primary care setting, in an outpatient setting, the audit, the cage, the craft. They're quick. They can be done quite simply. There's even a single question, validated question about how many drinks in the past year have you had, how many times in the past year have you had 5 or more drinks as a male, 4 or more drinks as a female? And if they've had heavy drinking days, you can go on to ask more questions thereafter. So this screening is important, and it actually actually can be done rather in quite an efficient way. And also what's important is to know what a standard drink is. So to be able to talk to your patients about alcohol use and then quantify what is high risk, what's low risk, and what meets the criteria for an AUD, you want to know what a standard drink is. So for beer, it's 5%, 341 mils is one standard drink. For wine, 5 ounces, distilled alcohol, 1.5 ounces. The reason why I bring this up here is most times I've seen my patients will say to me, well, I don't really measure how much I'm drinking, doc, so I can't really tell you. Well, then it's important to say, okay, this is what a standard drink is. So do you buy, if you're drinking vodka, a 26-ounce bottle once a week? Do you buy a 40-ounce bottle? How many days does it take for you to get through that? And you can use that information to kind of go back and figure out potentially how many standard drinks they're actually having. And then you can quantify those and help support them more. And one way to do that is to know the low risk alcohol drinking guidelines. So to reduce long-term health risks, the recommendation of these guidelines is to drink no more than 10 drinks a week for women with no more than 2 drinks per day. And for men, 15 drinks per week with no more than 3 drinks per day. And they recommend to plan non-drinking days in between. Now, the low-risk drinking guidelines are actually based on prospective population-based data. So it's not rigorous data. But what this expert committee has done is they've looked at what data does exist with regards to premature mortality and alcohol use and tried to sort of discern an amount that would allow people to have the same risk as somebody who may not be drinking alcohol when it comes to premature mortality. And what we do know about alcohol is even 1 to 2 drinks a day can actually significantly increase one's risk of cancer, for example. So, but it is recommended both by our recent provincial AUD guideline and in other guidelines to actually still utilize this low risk drinking guideline to be able to have these conversations with patients and to use this as a guide to better support them. So for youth, the recommendation is to drink no more than 1 to 2 drinks at a time, no more than 1 to 2 times per week, but really to delay your drinking until adulthood. Now, what we do know about youth is that they experiment with alcohol and substances. And so when you're screening youth, it's important to really, use a patient-centered approach to say, have you drank alcohol? Use one of the validated tools. And when they start to open up, to say, use a motivational interviewing approach to really see how they feel about how much they're drinking right now, if they've had any negative effects or any positive effects, to really explore that with them, but then also share with them what the recommendation is for youth and consuming alcohol. And that approach may help them want to continue to engage on their alcohol use. If it becomes more problematic, reach out. But if not, it's something that you've educated them on in a non-judgmental way. So if you screen people for alcohol use, if they're low risk, you want to continue to review the low risk limits, encourage them to stay within it. But if they're above the low risk limits, you want to then screen for an actual alcohol use disorder. So you want to go through the diagnostic criteria of DSM-5. It's 11 simple questions that you can ask. You only really need 2 or more to have a mild alcohol use disorder. And then it gets when you meet more criteria, you're moderate or severe. So I'd recommend getting familiar with the DSM-5 and essentially drinking above low risk drinking guidelines, but not having an AUD diagnosis, you really want to engage them in brief intervention. There's good data to support that, and I'll get into that. But if the person meets the criteria for an alcohol use disorder, then you want to do brief intervention in your office when you see them. You want to provide pharmacotherapy, plus or minus referrals for psychosocial treatment options. And I, again, will review those with you as well. So brief interventions, we do this every time, I'm sure, we see our patients on various matters. These are time-limited sessions, 5 minutes, grounded in motivational interviewing and taking a harm reduction approach. So this Cochrane review from 2009 looked at brief intervention for alcohol use disorder, 34 RCTs. Participants that received brief intervention in primary care settings were found to have lower alcohol consumption compared to control after 1 year or follow-up or longer. And meta-regression showed that short sessions, 5 to 15 minutes, seem to have as big of an effect as longer interventions. So just to say that, that those 5 minutes that you spend in your office to touch base again, a month ago, we talked about how much alcohol you were drinking. How are things looking for you now? How are you feeling about that? Have you noticed any positive or negative effects of that? So to be able to engage in those conversations, to continue to provide this brief intervention has shown that it'll help lower consumption and improve engagement of your patient. So I'd like to really briefly get into withdrawal management, just because many of you likely work in outpatient settings. So if a patient presents and says, look, over the pandemic, I've been drinking every day. It's been a year and a half and I need to stop, and I want to stop today. So I'd like to sort of show a few slides on how you can make a decision as to whether or not your patient would require inpatient detox or not. So there's a tool that many of you likely have heard of. It's called the PAUSE tool, the Prediction of Alcohol Withdrawal Severity Scale. So it's a 10-item risk assessment tool, which is a tool that will assess whether the person sitting in front of you what their risk is to develop moderate to severe complicated withdrawal or not. So it's found to be the most useful screening tool for predicting a patient's risk of developing severe alcohol withdrawal. And it can be used to help determine who can be managed as an outpatient versus which patient you want to refer for inpatient monitoring. So this is the 10-item score. It needs to be administered by a clinician. And there is a question in this score that looks at the person's actual blood content level. And obviously in the community, many of us don't have access to that number if they present that day, but that can be replaced with a question about whether or not they drank in the last 24 hours. And so the AUD guideline does make that amendment to this PAUSE score and still recommends that it be used in the community. And essentially, if somebody has a score of 3 or less, you can actually consider outpatient management. You can avoid unnecessary admissions to acute care or detox. It's more cost effective and less disruptive to the person's life. However, the PAUSE tool is one part of your clinical assessment. So if you do a pause and the person in front of you hasn't drank in 10 hours and they're tremulous, they're diaphoretic, they're extremely tachycardic, you may think, okay, well, despite your pause being 3 or less, you in fact are in enough withdrawal that I don't feel comfortable you doing this as an outpatient. So really, this tool needs to be used in conjunction with your clinical assessment. And to ensure that if you are going to detox someone in their home or in the community, that they're able to commit to daily check-ins, either a phone call or a visit for at least 3 to 5 days. They can take oral meds, and also that they have somebody at home, a friend or a family member that can check in with them. And the reason for that is PAUSE isn't a perfect tool. So if someone does start to develop more severe withdrawal, you'll know with your daily check-ins, or the family friend can bring them in. So if somebody does score 3 or less and you've made the determination that they're safe to detox at home, you can actually use a non-benzodiazepine treatment approach. Traditionally, diazepam tapers have been used extensively in the community to help detox somebody. However, that's not the current recommendation. And the reason is that benzodiazepines have a very long half-life. Diazepam, for example, has a 20 to 100-hour half-life. So if we load somebody with diazepam in the home and they're no longer in withdrawal, their risk of overdose is quite high if they relapse to drinking, and relapse rates are high post-detox. And so in fact, this guideline recommends using things like carbamazepine, gabapentin, or clonidine instead to actually help detox folks if their pause is 3 or less. And based on your clinical assessment, they haven't had any previous history of seizures, etc., then you can actually avoid benzodiazepines and avoid the harms of those medications. I won't get into the specifics of dosing of these medications, but I highly recommend you check out this AUD guideline on the BCCSU website to be able to look at their tables. They have really great tables on which medications to use, the dosing, some of the common side effects. And also they go into a lot more detail about discerning whether someone can have an outpatient detox or not. So again, if someone has a pause of 4 or more, they're actually at a high risk, a moderate to high risk of developing complicated withdrawal. So for those patients, inpatient management is what's recommended with a benzodiazepine regimen. So benzos are first line in an inpatient setting to manage alcohol withdrawal. So that's my really brief summary of trying to manage alcohol withdrawal in the community setting, but please do refer to that guideline to get more information. So now the meat of the presentation is relapse prevention, pharmacotherapy. And so I named this harm reduction, recovery management, relapse prevention, because really it depends on the goal of the patient. So maybe their goal isn't to stop drinking, but you're going to reduce harms by using some pharmacotherapy, maybe some other methods. Some may want to manage their recovery or prevent relapse to alcohol use. So these are various terms that can be used to help describe a patient's goal. So all patients with AUD should be offered a range of evidence-based pharmacotherapy, psychosocial treatment intervention, and recovery support services. And each patient may need to try multiple approaches of varying intensities along this continuum. And I'll go back to something like diabetes. So, I have a patient who was managed on just oral medications. They had an extremely stressful event occur in their life. Their diet changed and their A1C went up to 12 from, I think it was 7. We ended up initiating insulin, and we were managing their blood sugars. And over time, things changed for them. And they were able to actually come off the insulin and just continue with oral medications only and diet control. But the point of that story is that much like diabetes, alcohol use disorder is a chronic condition and it relapses and remits. And at certain points, people may need pharmacotherapy, psychosocial intervention, along with other services, versus at some point they may be off pharmacotherapy and doing just great. And so checking in with our patients with AUD regularly, just like we do with our diabetes patients. The difference is with diabetes, we have this timeline, A1C every 3 months, and this is the sort of the protocol to use and the guidance, and it doesn't necessarily exist for substance use disorders. And I think it speaks to the stigma of substance use, and even in the medical community, where despite the high prevalence, the amount of funding that goes into research for these conditions is a lot less than what we see for conditions like diabetes and hypertension, even though many of the hypertension may be caused directly because of alcohol use. But nonetheless, just I guess I'm belaboring the point that offering people a continuum of care when they have substance use is really important. So back to pharmacotherapy. So all patients with moderate or severe AUD can be offered pharmacotherapy, but if someone has a mild AUD, but they have strong cravings and they've really been trying to drink less, they also can be offered pharmacotherapy, and we can talk about options for them. It can lead to improved outcomes with AUD, including preventing return to any drinking or return to heavy drinking, reducing the number of heavy drinking days, reducing the number of drinks per drinking day. And it's underutilized. So less than 10% of patients in Canada with an AUD are offered pharmacotherapy. And like I mentioned earlier, in Saskatchewan, it was 1.3% based on this one study. So definitely an underutilized option to help reduce harms of alcohol use. So what is available? So what's approved and first line are acamprosate and naltrexone. Disulfiram is approved, but not recommended by this guideline, and I'll get into why. Off-label or second line are topiramate and gabapentin. And I'll get into all these medications. So first line medication, naltrexone and acamprosate. A 2014 meta-analysis of AUD pharmacotherapies delivered in outpatient settings found that acamprosate and naltrexone were associated with a significant reduction in return to drinking in comparison to placebo. When directly compared with one another, no significant difference between the two was found. However, several other systematic reviews have concluded that while naltrexone and acamprosate are similarly effective overall for the treatment of AUD, naltrexone, in fact, appears to be more effective for reducing heavy drinking with a number need to treat of 12, while acamprosate is more effective in supporting abstinence from alcohol with a number need to treat of 12. And so just really briefly, if you compare that NNT to statins, warfarin, and Wellbutrin, their number need to treat is far higher, but also that we are prescribing these medications more often because of the level of comfort with these medications. So just a plug for pharmacotherapy for AUD, and knowing that they're safe medications to utilize, they're underutilized, and there is good data to support it. So getting a bit more into specifics of these meds. So naltrexone, it's an opioid receptor antagonist. So what it does is it antagonizes the opioid receptor in the body. It blocks the euphoria associated with alcohol consumption. So it reduces cravings for alcohol. So essentially, if there's a restaurant where they have really great wine and you've made reservations, that may, suddenly you're craving drinking that day. Your dopamine pathway has been triggered. Your endogenous opioids have activated the opioid receptors, and you sort of have this craving to drink that specific wine that day. Maybe you're meeting a friend who you drink with often, and that may, make you think of wanting to drink. And so those are all, different things that can happen for somebody that can trigger that pathway. And naltrexone can help dampen that response by blocking that opioid receptor. For dosing, the target dose is 50 milligrams. I often start a bit low at 12.5 for 3 days, up to 25 for 3 days, and up to 50. If somebody's tolerated this ago just fine, we can give them 50 right away. Some patients do experience mild side effects like nausea, headache, and GI upset, and that can be enough for them to not want to take the medication. And so titrating a bit slower can help mitigate some of those concerns. With regards to safety naltrexone, it is recommended to check LFTs at baseline, 1, 3, and 6 months thereafter. There is a risk of hepatic injury because naltrexone is hepatically cleared, and it is advised to stop if you are seeing symptoms of acute hepatitis. And of course, you want to check their blood work at that time. Some side effects: nausea, headache, dizziness, like I mentioned, generally mild. Many people don't experience any. This is once a day dosing. I often recommend patients to take it at night. Contraindications: current opioid use, and then acute hepatitis or liver failure. So with, not frequently, but in the inpatient setting where I work at St. Paul's, every now and again, I'll meet the patient who comes in with severe precipitated withdrawal because their well-meaning practitioner started them on naltrexone for their severe AUD. But what the practitioner may not have known is that they're on methadone from a different provider for the last 20 years, but they just didn't want to bring that up. Or that they'd been buying T1s over the counter to kind of treat their chronic back pain, and they didn't think to share that. And so then they end up getting precipitated withdrawal because they also started naltrexone. So you really, before starting, want to ask in various ways, are you taking any opioids over the counter, prescribed or otherwise? Because you really want to avoid naltrexone in those patients. And when it comes to acute hepatitis or liver failure, I just want to show this letter to the editor where an addiction physician in Australia wrote that continued heavy drinking is much more likely to pose a greater risk to liver function than naltrexone. Arguably, the risk-benefit assessment likely favors naltrexone treatment. And there's a reference below, and I'll be sharing these slides, that gets into hepatotoxicity of naltrexone in the treatment of AUD. The doses you use for the treatment of AUD, aren't high enough to be causing the liver injury that we're really concerned about. But if somebody already has synthetic liver dysfunction, you want to be cautious with naltrexone. I do think the risk-benefit assessment is really important. So if naltrexone helps somebody drink, who was drinking 40 ounces a day down to 12 ounces a day, then arguably the benefit to the liver is far greater. I often, if someone has decompensated liver failure, consult GI. My patients are often being followed by a GI already, and I have yet to have a GI doc that says, no naltrexone. In fact, I continue the medication and we do close monitoring. But of course, if it's not having an impact on their alcohol use, then I would stop it. But just a little plug for the concerns about hepatotoxicity and naltrexone. Acamprosate. So mechanism of action of this medication, not fully understood, but believed to restore the imbalance between glutamate and GABA. So when someone drinks chronically, alcohol activates the GABA receptor. You have a bunch of GABA neurotransmitter that's quite depressing, and it further can inhibit the NMDA receptor. So you don't get the same excited part of the brain activation. And so that dysregulation, acamprosate may help regulate some of that or restore that. The dosing, it's 666 milligrams 3 times a day. It's quite onerous. It's TID dosing, it's challenging to take, but the side effect profile of acamprosate is quite mild. Most commonly, some loose stool, which can usually be transient. The other contraindication is severe renal impairment. So if your GFR is less than 30, it's contraindicated. If you're breastfeeding, it's contraindicated. But if your GFR is greater than 30, you just reduce the dose in half, etc. So you want to watch out for renal failure when it comes to acamprosate. So first-line therapy is how to choose. Naltrexone is recommended for patients with the goal of either reducing their drinking or abstinence. Acamprosate, on the other hand, is recommended for patients with the goal of abstinence only. Other considerations are contraindications, dosing schedules. So my go-to medication, from my own experience, is naltrexone, mostly because it's once a day, it's well tolerated, and I find taking anything TID, even for myself, let alone my patients, it's quite challenging. So I do like to use naltrexone, especially because it both has data for abstinence, but also reducing heavy drinking. In the studies, often the response was improved when initiated following 3 to 7 days of abstinence. However, both of these medications are safe to start while someone is actively drinking. And it's safe to continue these medications if they do have a relapse to alcohol. So if there is a short alcohol relapse, you instruct your patients to continue their medications throughout that time. I apologize, I'm going to get a bit speedy. I think I took a little too long in the beginning, but I have a few more slides to get through. So disulfiram, also known as antabuse, is an aversive agent. This is approved in Canada for the treatment of alcohol use disorder, but the data doesn't support it to a great extent. So essentially disulfiram causes an extremely unpleasant reaction when someone drinks alcohol. So disulfiram doesn't work on the neuronal pathways that affect alcohol craving, tolerance, etc. It actually just is. And so if you drink, you feel terrible, versus actually trying to mitigate some of the neuronal pathways that that lead to excessive drinking or an alcohol use disorder. What disulfiram does is it blocks acetaldehyde It blocks acetaldehyde dehydrogenase, resulting in accumulation of acetaldehyde, and that results in flushing, hypotension, palpitations, diaphoresis. In somebody with unstable coronary artery disease, this can result in emergency situations. There is some support in the literature, but the effects often dissipate in real world conditions. So essentially, there are RCTs that look at disulfiram being better than placebo in monitored settings. but there's an extensive side effect profile that I would suggest that gets reviewed if you are going to start disulfiram for somebody. And it's not recommended by the guideline committee, but it may be an option for some individuals who have had benefit in the past, or who, who have a spouse or somebody in their life that a partner that would be administering it, and they really feel like it'll help. In certain situations, somebody may be in recovery, but there's a big event coming up or a wedding where they might feel triggered and they want to take disulfiram for the week. There are situations where it may be helpful, but really the data doesn't support the use of disulfiram for reasons that I've mentioned. And you want to be cautious in anybody with any pre-existing conditions that might be exacerbated by that unpleasant reaction that occurs from disulfiram when somebody does consume alcohol. So I really want to touch on second-line pharmacotherapy. If there's no benefit, or if there's contraindications to first line, you want to consider topiramate or gabapentin. They both haven't been compared head-to-head directly in a clinical trial. Topiramate, although off-label, is starting to have good data and emerging data, and it is recommended as first line in some guidelines in the States, for example. It's an anticonvulsant. There's a meta-analysis of 7 RCTs, and it reported small to moderate effects on abstinence and heavy drinking outcomes compared to placebo. The treatment effects were similar or greater than with naltrexone and acamprosate. Now, while we have more data for naltrexone and acamprosate than topiramate, there is early promising data for topiramate. The dose is 50 milligrams a day, gradually increasing over 5 to 8 weeks to 100 milligrams BID. Now, I've used topiramate a number of times. I start people at 25 milligrams and I increase by 25 milligrams a week to really avoid the side effects. The thing about topiramate is it does have an extensive side effect profile. Many people experience paresthesias and anorexia, nervousness, and I don't go up to 100 milligrams BID. Actually, I find that, even up to 75 once a day or 50 BID, there's quite a bit of benefit. And in fact, there are studies that look at using lower doses of topiramate, and they have shown positive outcomes on alcohol use. So really, I've used lower doses. Contraindications to topiramate are pregnancy or planning to become pregnant. Gabapentin, I think this is used quite extensively in this province when it comes to alcohol use. There is data to support that. There's 3 RCTs that have found gabapentin reduces alcohol cravings, rate of relapse, and number of days to relapse compared to placebo. One potential way to start somebody is given 300 milligrams on day 1, increased by 300 a day as tolerated to 600 TID. Some patients will tolerate 300 to 600 TID quite quickly because they're quite GABA dysregulated. Side effects, dizziness, somnolence, ataxia, peripheral edema. You want to use caution with patients who are also using opioids. We've got data to support that it increases the risk of overdose. Pregnant or breastfeeding over the age of 65. And of course, there is a risk of diversion with gabapentin. It can be used not as prescribed. But if you have patients who you started on gabapentin and you can actually really discernibly document that they've reduced their drinking, it's a worthwhile medication to continue. But if they're on gabapentin and they continue to drink, I would stop that medication. I wouldn't keep it going. And if you have patients who have stopped drinking thanks to it, then that is definitely something you want to continue for them. But often, I'll see in hospital that people are maintained on gabapentin that continue to drink, or maybe they've had a relapse and it's been, a number of days. So it's something to consider to either taper down, lower the dose, or stop during those times to help prevent harms of co-ingestion. So what about combining pharmacotherapy? So this systematic review of combined pharmacotherapies for the treatment of AUD in patients with comorbid conditions looked at 16 RCTs and various medications in combination with naltrexone. They found no benefit of combination therapy over single agents, but they did note the limited statistical power of these studies. And due to the heterogeneity of drug combinations, it was difficult to interpret across studies. And so they call for larger trials with combination medications to really truly know the effect. They did recognize, however, that combining meds to treat certain symptoms related to AUD or certain subpopulations may be beneficial. So, for example, something for their insomnia when they're in early remission, because that's really a huge complaint of theirs, that they have trouble sleeping when they've stopped drinking alcohol. So you really want to look at what benefits combination medication may have, but to know there isn't a lot of data to support it in the literature currently. However, when it comes to naltrexone and gabapentin, there is some data. So this RCT of 150 people were assigned to naltrexone alone, naltrexone and gabapentin up to 1,200 milligrams in the first 6 weeks, and this is a 12-week study, or a double placebo. And they found the combo naltrexone gabapentin resulted in greater abstinence rates and reduction in alcohol use in the early stages of alcohol cessation. That wasn't seen at the end of the 12 weeks. And so this is actually the combination that I most frequently use. So I'll start naltrexone, and if I'm doing an outpatient detox, it'll often be with gabapentin. And I'll continue that gabapentin for a number of days or weeks, and I'll slowly taper that down. Now, once I'm tapering it down, if I find people are cravings are coming back, or they're having more thoughts of alcohol, or they're starting to drink again, I'll keep them on that gabapentin along with that naltrexone. But my goal is to keep them on first-line therapy, which is naltrexone. But this is a combination that can be utilized. So very quickly, I reviewed pharmacotherapy, and I just wanted to put a plug in for psychosocial treatments as well. There is data for motivational interviewing. Several meta-analyses have reported small but significant improvements in outcomes compared to no treatment as usual, or education assessment only. We talked a bit about MI earlier in this presentation. Specialist-led interventions like CBT, family-based therapies, mindfulness can be really helpful. A meta-analyses have reported that CBT has a small but statistically significant treatment effect on duration of abstinence and relapse to any or heavy substance use compared to passive interventions or no treatment. And lastly, peer support groups, AA, Smart Recovery, no cost, low barrier. There's a lack of evidence that peer support groups are effective in preventing relapse or reducing alcohol consumption and alcohol-related harms, but it may be beneficial for some patients and families in navigating treatment and recovery. In fact, people may have a long history of going to AA and found that helpful in their 20s and 30s, and now that they may be drinking again in their 50s and 60s, is something that you want to help support them to get access to. So summary, universal screening. We need to ask everybody about alcohol use, adolescents, youth, adults, older adults. Use the pause tool as something in your outpatient clinic to really help determine if someone is low versus high risk of severe withdrawal. Do they really need to wait in line for detox, or try and get an admission to hospital, or can this be done in the community? I recommend using the RACE line. If you have questions when you're using that pause tool, if the person in front of you is there, you're trying to assess them and you have some questions, it's a good way to get a bit of additional support when you make that determination. Adults with moderate to severe AUD should be offered first-line pharmacotherapy, and where first-line doesn't work or there's a contraindication, consider the second-line off-label medications as well. Primary care clinicians should provide MI based on counseling to support patient-identified treatment goals. And of course, referral to psychosocial treatment is important and can be provided, but it really depends on what the patient would like to do and what their goals are. So again, crediting the BCCSU AUD Guideline Committee, where I've used a lot of the recommendations today, and then crediting UBC CPD for some of the images and content that I've used today. So thank you so much. I think right at 40 minutes, there's my email address. If you have any questions that maybe I don't get to answer today, feel free to email me, and I will be definitely be sharing the slides. So thanks for your attention.
Okay, great. Thank you, Dr. Brar. We get lots of questions in the chat, so I'll just go through them. I think you've addressed some of them already, but I will just go through the questions. So one person asked, do you always recommend titrating naltrexone up to 50 milligrams, or do you ever leave at 25 milligrams?
That's such a great point. I haven't left it necessarily at 25, but I can see where some patients may find that works just fine. And so, if someone's tolerating 25, they're likely going to tolerate the 50, and that is sort of the target dose. But if you're finding that the patient feels they don't have any cravings and they are not drinking alcohol, or the goals that they have been met, then you can definitely leave them at 25. And alternatively, I have increased people's naltrexone over 50. So if I have a patient who's on 50 milligrams, but they still have cravings, maybe at a certain point of the day, or because of certain things that are happening in their life, I'll go up to 100 milligrams. I just ensure that I'll monitor their liver function moving forward. And then sometimes that bit of an increase can really support them in the way that they need.
Great. And I know you mentioned AA programs and 12-step programs. So one person asks us, so these programs have advocated for strict action-based approaches being promoted. So which is more effective? Is there literature looking at this question?
So there is literature looking at using a patient-centered approach. and that, there's actually a lot of controversy in the literature as I was preparing for this presentation, seeing what's, new and recent, discussing about outcomes and how some studies look at reducing heavy drinking. And some, researchers feel that that isn't enough to prove that it'll reduce harm. In fact, abstinence is what we should be looking at. So there's a lot of controversy back and forth in the literature, but I would say if the patient's goal is abstinence and they found that AA or 12-step was something that really worked for them, that's when I would help support them, maybe print out a list of AA in their community for them. But those that want to reduce their drinking and, aren't interested in abstinence at this time, then absolutely, then that wouldn't be for them. So I think I would just, there isn't any concrete data one way or another at this point. There is some controversy out there. I would say you make that plan with the patient, and depending on where they're at, you may offer them or remind them of AA down the road if that's where they're at. But I would say it depends on what the patient's goal is.
Excellent. Yeah, just one more question about naltrexone. One person asked whether whether injectable naltrexone might be on the horizon in Canada.
Oh, I wish. So it's not. The last I've heard from the CSU is, in fact, the lobbying to try and make that happen wasn't successful, and we don't have that on the horizon. If someone else on the call knows better, please jump in. But that's not something that's available. It really is unfortunate. Although I was reviewing the literature for injectable versus oral, and it doesn't seem to have improved efficacy in abstinence over time, but it really takes out that whole issue of compliance or daily taking a medication. So unfortunately, I don't think that's coming down the pipeline anytime soon.
Sure. This one questioner asks, they're seeing increased use of naltrexone and camprosate as initial therapy. Any data or experience with this approach?
So using the combination, there is some data that looks at that. And there was a systematic review and meta-analysis, actually the one that I had popped up there, that showed that there wasn't any improvement in single agents alone. But there are other studies that have compared them head to head, where they've combined the two or done single agents. And they found that combining naltrexone and a camprosate improves outcomes compared to a camprosate alone, but not naltrexone alone. So again, the statistical power of these studies is low, the effect size is low. So I would say that because the prevalence and the morbidity and mortality of alcohol use is so severe, that if you find that your patient's on naltrexone and you added some camprosate, and somehow that's improved that dysregulation of GABA and glutamate, and it's helping, it's a safe medication, and I know we should be evidence-based, but I think taking that risk and benefit into account, and if that's working for your patient, I say go for it.
Okay. And how long do you treat with naltrexone? Is it lifelong?
So there isn't anything in the literature that supports duration. The guideline recommends 6 months to a year of support. So, and I would say, along with any other substance use, when it comes to pharmacotherapy, oftentimes people use substances for a reason. And when things start to improve, when they're not using substances, they've reduced how much they're using, it can be considered that you start to do a taper on their medications with regular follow-up. But, based on expert guidance, 6 months to a year, but there actually isn't any literature to support an exact timeline. Can patients stay on naltrexone lifelong? Absolutely. It's an old medication. There's good safety data out there. And so if that really helps them not use, then I would say the harms of relapse are far greater than long-term naltrexone therapy.
Good. Have you any success with naltrexone PRN? So this person says pre-anticipated drinking or with cravings, and if so, what sort of patient characteristics generally indicate that this approach might be effective for them?
Absolutely. So in my patient population, I haven't seen that be effective, because I see a lot of people with regular daily alcohol use, but there is data to support, and now it's going to escape me, but there's a name for this method where you use it PRN. So I think that it's a valuable thing to try. And so if somebody, binge drinks on the weekends, they have falls, maybe a DUI, and all these harms that come with binge drinking. In fact, there's far greater morbidity and mortality associated with binge drinking than there is with regular daily drinking. That may not be binge pattern. So if someone blacks out on the weekends and you start them on naltrexone just Thursday, and then they take it Friday, Saturday, Sunday, and that helps them drink less, there is data to support that. I just can't remember the name of that method. Is it
possible, maybe it's linked to the next question, the so-called Sinclair technique of intermittent use of naltrexone introduced in Finland. So this person asks, is there any follow-up over the past 2 decades?
On that data, that's a great question. And I'm very happy to look that up and send that out when I send out that presentation. So I'm not aware of any follow-up data. I did do a bit of a search last week to see what's new and upcoming in AUD, and I didn't see anything on the Sinclair method that's updated, but I didn't specifically look. But I would say I've offered that method to patients before, and I would encourage that if you have patients that only drink on weekends. Or like I said, some people take disulfiram before a wedding because they don't want to, they feel like that's a high risk event for them. Naltrexone similarly, if they feel like they may drink more they'd want because of whom they're around or the event, then it may actually reduce harms. So it can be trialed.
So this person asks about the 12-step programs again, suggesting they're low effectiveness rates over the long term. It obviously works for some people, but can also continue feelings of shame and therefore hiding relapses, which can be dangerous. Mm-hmm. So there's also a high risk of overdose following terms of total abstinence. Do you want to comment on that?
Sorry, I don't know if I caught it, Alan. So high risk.
So it is suggesting that there's talking about these 12-step programs and whether there is a higher risk of overdose following these terms of total abstinence.
I haven't seen, of course, with opioids, that is really clear-cut data that, periods of abstinence doubles your risk of a fatal overdose. But when it comes to alcohol, it's not something that it's come across my table. So I'd love to hear more about that. But, it's true that taking sort of a approach of abstinence only, the data didn't support that for the longest time. There is a recent Cochrane review that I didn't review before doing this talk, but there is emerging evidence for AA, I believe, in that Cochrane review. So I guess, long story short, I think that, traditionally we have said you need to stop drinking, and it hasn't worked. And so really allowing the patient to guide where they're at is important. And so, if someone hasn't drank in 6 months and they go from drinking nothing for 6 months to, having lost tolerance and drinking 26 to 40 ounces, I think that makes sense that they could have, a blackout event or overdose. I just don't know the data on that.
Right. So this person asks if you can comment on the mechanism for topiramate helping with AUD.
Yes, it's not fully understood. And topiramate helps with, oh dear, that's something that I'll share in follow-up email because it's lost me, but it's not a fully understood mechanism as well, but an important one. And I do remember recalling this not long ago. So apologies, I will get back to you on that one.
Okay. And any thoughts on GABA supplements?
So not gabapentin, but just like
this is GABA supplements. I'm not exactly sure what they're talking about.
Yeah, I mean, nothing that I've seen in terms of data, and even gabapentin itself does have some supporting data, but it's not extensive.
Yeah, and this person asks about a reasonable length for a trial of any of these medications before deciding whether it's working and moving on to something else.
Yeah, so I mean, in the studies, a lot of them are, 12 weeks to 16 weeks, some a little bit longer, up to 6 months. And so I would say, there isn't really a steady state that's required for many of them. So I often recommend continuing medication for the month at the very least. And if there really isn't any change, trialing something different would be an option. Oftentimes patients really associate alcohol use and combining prescribed medications as a dangerous thing. So that's something you want to do a lot of education on. People will say, I tried naltrexone and it just doesn't help me, but often they're not taking it because they've either relapsed to alcohol use or they continue to drink and feel that they shouldn't be combining the two. And so really sort of digging into what they mean by the fact that it hasn't helped them at all, and then moving on to other agents.
Mm-hmm. So this person's wondering about your drug of choice for an individual with both an opioid use disorder and AUD. Would it be acamprosate? That's
right, first line. But if they want to reduce heavy drinking, it would be topiramate, because acamprosate doesn't have any data, and nor have I seen any benefit of reducing heavy drinking. So for those folks, it would be topiramate. And for those that, want abstinence from their AUD, then it would be acamprosate first line.
What about any evidence for the use of baclofen for management of AUD?
Yeah. The AUD guideline gets into some of that. It's really limited data. So baclofen and ondansetron have some data, but it's limited enough that it's not recommended.
Okay. This person asks, how do you address adherence for patients who aren't able to take medications multiple times a day due to their level of intoxication later in the day, such as gabapentin, TID? So
absolutely. So adherence to TID regimens is a huge challenge. I don't find I think over acamprosate, gabapentin has some other benefits that people find helpful, so they'll take it more likely. I mean, it helps with anxiety for some, it helps with some insomnia, so people may be more inclined to take that. But the acamprosate I find is limited. I've had limited success with it actually because of the TID dosing. And so the one thing I would note that is if someone in the evening is quite intoxicated and they miss that gabapentin dose, all for the better. And I would probably change them to a BID dosing, in fact, and maybe address what's happening in the evening and maybe do naltrexone in the evening if possible, or something different, because then combining gabapentin when they're also consuming alcohol does put them at risk.
Do you ever use pregabalin instead of gabapentin?
Yeah, I know. I haven't, but there is some data to support that. I know that pregabalin isn't covered like gabapentin is, so I've never used it, but I would say that I wouldn't recommend it based on the current limited literature of pregabalin, but there is some, and I did come across that recently.
What about routinely supplementing people with the thiamine or 100 milligrams daily, vitamin B6 or folate?
Absolutely. And so, I think the prevalence of Wernicke's is like 1.8% in the general population, just because not only just alcohol use, but also just nutritional deficiencies. So I think that supporting people with thiamine is an important thing to do for people that may have really chronic AUD and drink throughout the day and not consume a lot of calories otherwise from food.
So what about the patients that has comorbid depression with AUD? Is sertraline the best antidepressant, or any evidence that it reduces alcohol use on its own?
Not on its own, but there is data to support sertraline in conjunction with naltrexone, for example, for somebody with depression and AUD, that it reduces the depressive symptoms and in conjunction with naltrexone can help support abstinence or reduced use. So that is my go-to SSRI. I think that, as people start to reduce their alcohol use or are not drinking, you start to see some of the things they may have been treating with alcohol use, like severe anxiety, whether it's social anxiety or generalized or depression. They may have more reoccurrence of the trauma they experienced. And so really then addressing the concurrent mental illness that may exist is really an important thing to do. And so in early remission, supporting them first with that remission, but also addressing the other needs. So yes, there's data to support sertraline, and there's good safety data of sertraline and naltrexone. And so that is my go-to antidepressant.
Okay. This person asked, they've seen a recommendation that naltrexone can be used 100 milligrams PO every day, or every other day, or 150 milligrams PO every 3 days. I'm curious if you've seen this in practice, and has it worked well for your patients?
Yeah, I haven't seen it much in practice. I would say that, I tried this with iron where they say take it every other day, but I also find that it's a challenging thing with compliance then if you're not taking something every day. So personally, I use 50 milligrams once a day, just based on, most of the data supports and what the guidelines support, but I will go up to 100 or 150. And considering the half-life of naltrexone, I'm not sure that, and this is just me thinking on top of my head, that a Q2 day dosing would be as helpful if they do have a regular and daily alcohol use disorder. So you might see some of, dissipation of the effects of naltrexone if it's not being taken every day.
Right, you mentioned iron, but what about other vitamins that you might recommend, and perhaps at what dose?
Yeah, I mean, thiamine is definitely one that I use. Often folate is something that I use, especially if there's certain medications that folks are taking, whether they have, co-occurring epilepsy. Vitamin D and calcium are the only other two that are covered, not specifically to someone's alcohol use disorder, but if I did a deep dive into the literature on vitamins, I would say that firstly, I need to do that. But secondly, that thiamine and folate are the two main ones that I would use, more directly related to deficiencies secondary to alcohol use.
So, yeah, this person talked about patients complaining about the cost of naltrexone and can they get it free of charge? So maybe you want to comment on whether that drug or others are covered here in BC.
Absolutely. So if you sign a collaborative prescribers agreement, and you need to sign one as a prescriber once a year for acamprosate and naltrexone, that medication then is covered based on someone's pharmacare plan. So they may have a small deductible, but that medication is meant to be covered thereafter. And so that the last I'd heard that the ministry was doing away with the CP exists. So that's one way to help get some coverage for your patients for acamprosate and naltrexone. And through Plan G, gabapentin and topiramate, I believe, can be covered through that plan. But it is true that naltrexone, I think, costs about $3 a day and can be a major barrier for people in using it. But sometimes when you compare it to how much maybe the alcohol is costing them a day, it may be a way to help mitigate their thoughts around that cost, but it may just be a total barrier. But the CPA is one way to try and get that medication covered.
And does the ministry remind you to renew it, the yearly form?
They don't. The pharmacist will just send you a fax being like, it's no longer covered. Please fill out your CPA.
Yeah. Okay. This, I think, was going to be the last question. I think we've got 2 minutes left. Yeah. This person says, I'm on an advocacy committee for families for addictions recovery. And we're looking at the question of coverage. Of course, you talked about that. It varies from province to province. There is the claim there isn't enough evidence for some products, I guess. And this person says it's simply not true. And so she put her email in the chat box that you can take a look at afterwards.
Okay, so that sounds great. And I would agree. I think, the effect size of some of these studies is small or modest, but when we look at the effect size, we really have to think about the context. And in alcohol use, the prevalence is high, the morbidity, mortality is high. So it really is important to still trial medications to help reduce some of those harms. But again, some of the controversy in the literature around, the actual rigor of the data and the effect size, because those do remain small at this point.
Good. That brings us to the end of our talk and the end of the questions as well. So that you spoke at the right speed. So thank you very much.